So in this video, we are going to build upon our initial overview of the phases of healing and specifically look at the proliferation or repair phase and the remodeling or maturation phase. So looking back again, we've talked about, controlling hemostasis. We've talked about inflammation. So now we've got these last two that we'll focus on during this time. During the proliferation phase, we'll see that fibroblasts and myofibroblasts are going to be most active. And then in remodeling, we're going to see type 3 convert to type 1 collagen. So for the proliferation phase now, we're looking at generally starting somewhere around day 5, but again, you can see how we have a bunch of intermixing here that occurs, and it depends on the extent of the injury. But again, think of this more as a continuum where you can see some blue all the way over in here and see some orange coming in there. But we're looking at day 5 all the way out to potentially day 21 with that. But you can see again early on, right around that second week, we start to see more of the maturation phase again starting to take place. So we're looking at about day 3. Sometimes you'll see out to day 14 on the shorter end. You can see day 5 all the way out to day 21 sometimes as well. So looking back now at the end of the acute inflammatory stage, we started to see that we had the growth of new capillaries that will continue and be a prominent portion of the repair phase. We've seen that macrophages have started to come in there, and they have started to produce that type 3 collagen with that. And now in the repair phase, the fibroblast, osteochondroblast, or osteoblast, I'll use fibroblasts as the example, just understanding the osteoblasts do the same thing but in bone, and chondroblasts are similar in that. But we'll see in this repair phase now the fibroblasts start to take over and continue the work that is started there. So the proliferation phase will occur via one of 3 possible outcomes, whether or not we have a resolution of the injury, right, which is basically all we need to do is clean up the cellular debris. The original tissue is left intact, so there is going to be a very short proliferation phase as well as maturation phase because the original cells are still intact. Regeneration occurs in areas where we have a significant amount of ability for the tissue to be replaced with similar tissue. These occur most often now in labile cells here, which are always undergoing mitosis anyway and being replaced, and so we can get good regenerative capacities. Most of the time though, we're looking at a repair where the original tissue is replaced by scar tissue, and this is going to occur in stable cells, and then in permanent cells we may have absolutely no regenerative capacity, and sometimes because scar tissue cannot occur and not do the same focus, we have loss of function in the case of nerves, eyes, cardiac. Skeletal muscle is somewhere in between these here as well, where it has some regenerative capacity, but not a ton for larger injuries. So for smaller injuries, muscle will be more in the stable cells. For larger injuries, it would be considered more in the permanent cell function. So for an overview now of the proliferation phase, you can see here a little bit different in the total time, but that's okay because again, it's a continuum. We ended with a bunch of neutrophils and macrophages occurring at the end of inflammation. With that, you can see here where fibroblasts now become most prominent. We have the macrophages as well as stimulating the angiogenesis or formation of new blood vessels. Right, but you can also see now the fibroblasts laying down the type 3 collagen, the ground substance for that extracellular matrix as well. And then eventually we will see towards the end that fibroblasts also start with type 1 collagen, and the conversion of type 3 to type 1 collagen is characteristic of the remodeling phase. At the same time, we also will see myofibroblasts start to occur with wound contraction starting to occur as well. So breaking down the proliferation phase a little bit by its own timeline, as well as highlighting things. In the very beginning, we see that rapid increase in fibroblasts that we were talking about as well. And see here a little bit about how that occurs with that. But we're also getting that increase in angiogenic factors to allow for more blood vessels to occur. Myofibroblasts are starting to produce or be produced and are working on wound contraction. And then we have the collagen synthesis being very active, starting at that 5 to 7 days, laying down type 3 collagen. So when you think of the proliferation phase, I want you to think of three main components there: the revascularization, wound contraction, and then wound repair. That's what's most important, and that's what's occurring in this proliferation phase. So let's take a look at how that occurs. So for revascularization, we are going to have high energy demands with the increased activity of the fibroblasts, as well as whatever repair and regeneration might be able to occur there. So we're going to need the additional blood vessels to occur, so additional capillary formations. And so you can see here how we can just add capillaries. These little black dots there, right, represent the increase in capillary formation that occurs early on to allow for that increase nutrients, oxygen, fibroblasts, different things to get to the area that we need for healing to occur. For wound contraction, then, these is going to be produced by the myofibroblasts, and these are specific types of fibroblasts, and you can see kind of how they get activated there. They have a contractile property. So as they get differentiated, you can see the cell here, and then the different parts with the collagen coming off, but this has some ability to contract. And so as the scar is bridged over the wound, these myofibroblasts will contract and pull the wound together, so we get a decrease in the size. And so you can see here how the actual hole is much smaller than the original hole, and that occurs through myofibroblasts doing small contractile properties that allow it to pull that wound closed. So here we'll look at skeletal muscle as an example, and skeletal muscle is slightly different because it has more of that regenerative properties because of the satellite cells, but we'll just look at it from an example perspective, looking at how the wound is closed. So we see at the very beginning here, we have the open wound. We have, you can skip this or just think of these as fibroblasts opposed to satellite cells. We start to get the lay down of scar tissue as well from both the fibroblasts and the myofibroblasts. Right? We get more scar tissue laid down. At the same time, you can see the wound is getting smaller as the myofibroblasts contract to decrease the overall size, and eventually we're left with a smaller scar of collagen fibers bridging the original gap that was caused by the disruption of the skeletal muscle cells, or the tearing of the skeletal muscle cells. So the scar tissue is laid down by the fibroblasts, and they just lay down the collagen in a way to try to bridge that overall gap. So in this picture here, the blue dots represent fibroblasts, and this is just a animation component. And you can see as we go through, the fibroblasts move around laying down collagen. Right? The blue represents less dense. As it becomes brighter yellow and eventually red, it becomes more dense. So you can see how we filled in now the gap in between, and we just continue to lay down more and more collagen until it gets denser and denser. And the denser the collagen is, the more it is able to resist stress. And so this is where we will see the increase in the tensile properties of the tissue that was injured as the scar tissue is laid down with that. So eventually we get to a situation like here on the left, where the darker tissue or darker colors represent tissue now that was original tissue, whereas the lighter colors now is the new collagen that's been laid down to kind of bridge that gap. And you can see how by laying down the scar tissue, we've connected both sides, so that way if you were to pull on one side, you would also get the pull on the other side. So we've reestablished that ability of the rope to pull and resist those tensile forces. The last phase of healing is the remodeling or maturation phase, and this is the least understood, partially because it takes so long in its time. It can go all the way up to a year or even more that we're still undergoing this remodeling, because that's the body's natural way of continuing to replace. The scar will eventually start to respond to said principle just like the rest of the body does as well. So when we're looking at this phase, we're looking at collagen transition as the wound becomes more scar tissue, and because of that, the sensitivity also lessens as well. So this is the final phase. The number of fibroblasts, myofibroblasts, and macrophages is reduced to the pre-injury level. The number of capillaries is also reduced and returned to its normal level. But what we will see is the increase is in type 1 collagen compared to the previous type 3 collagen that we saw in the proliferation phase. So again, looking at timing, as early as 5 to 9 days, we'll start to see some of this reduction in fibroblasts and macrophages as they're not as needed with that. We will still then have, starting at 12, the type 3 collagen being converted to type 1 collagen by those fibroblasts. They're just not as prevalent in there. In 6 to 18 weeks, we start to see the reduction of the capillaries, and like I said, anywhere from 6 months to 18 months, we will get all of that completion of the healing process. So during the remodeling or maturation phase is when we will start to see the increase in tensile force, or the maximum amount of stress that a structure can withstand. It's important to realize that almost never do we get a 100% return to its prior function with that, as with regards to its ability to withstand tensile strength. Scar tissue just is not as good at its ability to return to its tensile strength as, or doesn't have as much tensile strength as the previous tissue does. During this time, though, we can get strength of surrounding tissues to increase, right? Which is why we can get this return often earlier, where we're really using compensation for the lack of tensile strength in there, because normal tensile strength is not going, of that actual injured tissue, is not going to occur for at least a year or more. So the tissue in the inflammatory phase, we see a huge reduction in its ability to resist tensile force immediately, which makes sense from the fact that we have had that tearing, and so the tissue has been compromised. During the proliferation in the remodeling phase, we will start to increase the farther we go out, and the more type 1 collagen we have, the stronger we will get. In the very beginning, the fibrin clot is providing most of the strength. Eventually, that changes to the type 3 collagen in the scar tissue, and then finally the type 1 tissue eventually there. And you can see the amount of tensile strength that we see at varying levels within there in different models, right, as well. And so you can see it's not perfect, and it's not really easy to understand how this occurs and when, because you can see, you know, in muscle, for example, 60% is returned in 6 weeks in rats, but 6 months in cats with this. So this is where a lot of this is just not well understood. The primary aspect of the maturation or remodeling phase is that transition or conversion of type 3 to collagen to type 1 collagen. And you can see here down in the bottom, this is representing type 3 collagen, right, where it's irregular in its nature. There isn't a great alignment compared to now the type 1 collagen, where there is much more alignment. It is still not perfect, but it's much more aligned in a singular direction, which makes sense because most of the time we see tissues designed to resist tensile strength in one direction or in one plane, right? It can go in either direction, but one plane, where we want, you know, the ligament or the muscle to resist stretch in a single direction. We're not as concerned about a ligament being torn, right, side to side. So any collagen that in this case was running in a, you know, up and down direction, so some of these fibers here would not be aiding or not be aiding as directly to the resistance of the tensile strength. And so it occurs the same way as the previous production of type 3 collagen, where again, the representing now the replacement of type 3 with type 1. So we're only seeing type 1 collagen being placed down now here, the fibroblasts moving around, increasing in density. But you can see the type 1 is being aligned to the stress. And so we'll see it's important in early mobilization and early motion that we are producing the stress, because what is occurring is we are breaking the type 3 collagen that is going in the wrong directions, right? Because it's being repaired and only being replaced now with collagen that's resisting the force. So if we have forces that we're applying to the tissue in this direction, then that direction is where the fibroblasts will produce the strongest collagen fibers, because that's what's being resisted. And so said principle still applies. We need to be applying normal, appropriate level of tensile forces to show the tissue how it's going to be expected to work. So in the next video, we'll look at some timelines for specific tissue healing, but the 3 phases are going to be the same for all different types. They're just going to occur at different timelines and in different methods.